Uh, Hello, thank you for having me. I'm Brian Jankowitz from the Cooper Neurological Institute in Camden, New Jersey. I want you to know that I have no qualms about giving this lecture. My conscience is clear, because if this were my symptomatic carotid at the age of 42, I personally would want it stented. I do open surgery, and yet I do not want to go under general anesthesia or have a knife put to my neck to revascularize my carotid. So bear with me. What I need to do today is to convince you that the upfront stroke rate for carotid artery stenting is higher than endarterectomy, but I think it can be reduced. That carotid artery stenting is a durable procedure with the same post-procedure event-free survival as carotid endarterectomy, but with a lower surgical morbidity, and it's continuously evolving and improving with dwindling anatomic restrictions, and thus I think you can argue that it should be your first-line treatment, particularly for symptomatic carotids presenting at your hospital. I think that both CREST and ACT 1 have shown us that the event-free survival after the procedure is equivalent between carotid endarterectomy and carotid artery stenting, and that the need for retreatment or restenosis is equivalent over the long term, and they even cost the same. Now, before I get into some of the nuances or the persistent evolution of carotid stenting and why I think we can get that procedural stroke rate even lower, I think it's worth looking at the static nature of carotid endarterectomy. This is DeBakey's account of his first carotid endarterectomy performed in 1953. And after he told the patient that this operation had never been successfully performed on a carotid artery, he wrote this operative note. Now, this is eerily similar to my same operative note for carotid endarterectomies that I perform today. The procedure really hasn't evolved since 1953. Neurocritical care has, anesthetic management has, but the procedure itself is done much the same way DeBakey did it in 1953. So we have a continuously evolving procedure against a static surgical procedure. And there are many technical nuances of carotid artery stenting that can make it even safer, particularly to lower the procedural stroke risk. We haven't seen a great new embolic protection device placed distally in the last 10 years, but there are a couple new ones in Europe that will hopefully be making their way into the US over the next couple of years. There are a plethora of different stents out there, so we can tailor the stent to the specific patient or anatomy. And for instance, I prefer using a closed cell design with the greatest mesh density or smallest pore size to prevent plaque extrusion, leading to stents that are dual layered or created out of a mesh that have extremely small pores to prevent plaque extrusion through it. So this is the Casper Roadsaver stent by Microvention that's currently under assessment. Every 6 months, we see some new technique, some new nuance of existing technology that is combined to make carotid artery stenting even safer, to reduce those procedural stroke risks. So now you can take a lesion, and before you ever angioplasty, you can place a long stent, place an indwelling telescoping stent, angioplasty for the first time, and I do think you can potentially reverse your microembolic hits or DWI signals by reducing plaque extrusion. Or you can use a belt and suspenders approach, proximal flow arrest with a standard balloon guide catheter with a distal embolic protection device, or even trapping a lesion with a proximal balloon and a distal balloon to almost completely inhibit any ability for distal thromboemboli because you can aspirate after you angioplasty and stent. And you can even configure your own flow reversal system with a transfemoral approach using a balloon guide with flow cessation and then hooking up a conduit to the femoral vein. Not quite as strong as the Roadsaver system or TCAR, but you can manufacture these systems and I think potentially provide some similar benefits that flow reversal provides you. Because I'm going to echo Dr. Matuk's comments that I really think that to get transfemoral carotid stenting down to the stroke rates that we see in carotid endarterectomy, we have to come up with a true proximal flow reversal system. Because the results you can't deny these results that if you compare CREST to the pivotal study for TCAR, the stroke rates are through a stenting technique done transcervical are better than we've seen through endarterectomy or transfemoral stenting. And if you look at highly comparable large registries with similar rates of symptomatic carotid stenosis, the stroke rates with proximal flow reversal are superior to transfemoral carotid stenting or even carotid endarterectomy. So let's talk about all those cases that we could consider as a first-line carotid stenting paradigm. These are the low-lying fruit: hostile neck, a high riding lesion, patients who are hemodynamically unstable, patients on whom you have a CTA that you know don't have a circle of Willis, no PCOM, no ACOM. These are the patients that have higher risk for carotid endarterectomy, prior CEAs, and young patients where the anatomy simply makes transfemoral carotid stenting easy and much safer with a very low procedural risk. Well, how about those patients that are classically considered hostile for transfemoral carotid stenting? Slowly, I've whittled away these patients, and I think that they are reasonable to consider as a first-line carotid stenting technique from the femoral approach. A calcified arch, well, now if we avoid drive-by angiography, avoid catheterizing unnecessary vessels, using neuro guide catheters that are more supple and more easily navigable into the great vessels, or if you go right radial, you can often get into the right common or a bovine left carotid without ever manipulating the arch. And the one segment of the population that I still consider for first-line treatment of carotid endarterectomy is a concentric calcified plaque. So a calcified rock that you see at the bifurcation, I still think that is the one anatomical variant that I prefer using a first-line endarterectomy approach. But the rest of these, severe tortuosity, now with the ability to use neuro guide catheters, or if you have trouble placing your distal embolic protection device, you can use distal access catheters to navigate through the double 90-degree angles and then deploy your distal embolic protection device, remove your DAC, and then perform a carotid stent. And if you have really difficulty placing the distal embolic protection device, you can consider flow cessation with a balloon guide or flow reversal. Type 3 arches, once again, transradial approaches, or even direct carotid percutaneous puncture techniques give us the ability in certain circumstances to completely avoid the arch. It's become easier than ever to place tandem overlapping stents in long or non-contiguous lesions. And for someone with a mobile thrombus in the carotid, personally, as someone who does endarterectomy and carotid stenting, I'd rather be in the angio suite with the patient on the table and the ability to visualize the intracranial circulation if I'm going to manipulate a mobile thrombus. So I think it is becoming more reasonable to consider carotid artery stenting as a first-line therapy for those patients. And finally, it's not just age. Age is simply a surrogate for how tortuous and calcified your anatomy is. And so I've talked about ways to avoid going through a hostile or calcified arch. So we wanted to prove this concept at the University of Pittsburgh. We had been slowly evolving toward a first-line approach of carotid artery stenting for most patients who present with symptomatic carotid disease. Well, we wanted to take a step back and really prove that this was safe. So we wanted to show that carotid artery stenting in the most heinous of populations, the ultra-early patients presenting with symptomatic carotid stenosis, that carotid artery stenting from a transfemoral approach could be equivalent to carotid endarterectomy. So we prospectively evaluated all patients who presented within 48 hours of a neurologic symptom, and if there was surgical equipoise defined by a CREST-2 certified endarterectomist or carotid artery stenter, these patients were pseudo-randomized. So what we did is we simply alternated therapy week by week because we thought that there was equipoise in the treatment at the University of Pittsburgh. So based on the day that you presented, you'd be offered either a carotid artery stent or a carotid endarterectomy by a CREST-2 certified physician. And then we looked at the primary outcome of stroke or death within 30 days. It's interesting to note that over the 178 patients that we evaluated over about 2 years, there was only 1 out of 90 patients that effectively crossed over from stenting to endarterectomy because of an aortic occlusion, and the results are as follows. Average age was 70 years, average stenosis by catheter-based angiography was 82% or 84%, so legitimate disease in symptomatic patients treated within 1 to 1.6 days. The only significant difference was we were able to stent faster, significantly, than the endarterectomies, and when we look at the outcomes, they were exactly the same. We had 3 events in the stenting group and 3 events in the endarterectomy group. Exactly the same outcomes if you look at stroke or death within 30 days. I think proving that you can consider an upfront carotid artery stenting approach even in the patients that have the highest risk. And the only thing to note is that in the patients we did ultra-early endarterectomies on, average time from hospital presentation to endarterectomy was 1.6 days. We saw 3 abrupt carotid occlusions, making me rethink how safe it is to perform ultra-early endarterectomy, but I think validating safety for carotid artery stenting. Thank you.